How do you decide what to do with a new patient or client? Good morning. Happy Friday. I have Neuro Coffee in hand and it is perfect. I have a much busier Friday than usual, so I'm going to dig right into today's Q&A. It's a little bit more on the decision-making end of the concepts rather than what we would typically talk about, where we're talking about cases or presentations or things. But it's a very important aspect of things because it does help us through our decision-making process as we work with a new client or a new patient. This will be skewed a little bit towards the physical therapy side of things as a background, but it's still going to apply to anybody that has to work directly with human beings, especially in the fitness and rehab industries. So this comes from Tim, and Tim's got a series of questions, and we'll knock them out in sequence here. But Tim starts with, as a physical therapist, how do you go about evaluating someone who presents with a musculoskeletal related issue, for example, buttock pain? So Tim, it's going to depend on some information as to how we're going to evaluate this person or how we're going to make our decisions as we move through this process. And so what we want to recognize is that these presentations are a little bit different. So for instance, somebody comes in with buttock pain, and so that's kind of vague, but what if they slipped and fell on the ice and landed on their butt, and now they come in with buttock pain? So now we can categorize them into this what would be considered a clear or an obvious presentation. It's one of these circumstances we would evaluate them with a lot of good information that would lead towards, okay, your butt hurts because you fell directly on it, and so now that seems obvious, right? And so we're going to treat them a certain way. So this is protection and promote adaptability and progressively restore normal movement. And so again, this is very straightforward. In fact, in some of these cases, they don't even need physical therapy because it is so obvious. They go, okay, I fell on my butt. I just need to protect it, take care of it, blah, 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 and eventually I'll come back to normal. Now, let's just say that they've gone through that process, and so they've treated it as this obvious kind of a thing, but now they've got something that is persisting, and so now they have this buttock pain that it seems like this thing should have healed by now, but they still have an issue with this pain, and so now they come to see us, and now we might categorize them as a little bit more complicated because we do know that something has happened in the past. We have that information available to us, and so maybe they've gone through some other diagnosis, so they come in with a known constraint change, and so they say, oh, I have this showed up on an x-ray, or this showed up on an MRI, or they're presenting with something that is mechanically familiar, so we see a relationship as we go through our relationship, and so we can identify a little bit more of the cause and effect that may be interfering with normal behavior. So again, this would be a situation, somebody fell on the ice, they go through the acute recovery, it seems to have gotten better, but they still have issues. And so now maybe they have like an adaptive strategy or an exaptive behavior that is promoting this ongoing pain. And so that's something that we can identify with our evaluation. Now, we can go to a third realm here where we're talking about a much more complex situation. So this is the land of the unknowns, and this is somebody that shows up with an insidious onset of buttock pain. So everything under these circumstances is going to be emergent. And so this is where we have to identify what we can identify. So we measure what we can measure, we intervene, and then we monitor the behaviors. And so this is where we see the emergent behavior, the response to the intervention, and then we would take the next logical step. So again, maybe we have some exaptive behaviors here that are creating interference or not. But again, this is where we rely on our structure, our orientation, our muscle and connective tissue behaviors. And our goal under these circumstances where we start in this complex domain is we want to get them moving into a complicated or even better, a clear situation where we can actually apply a best practice situation, because when we're in the complex domain, everything is emergent. We just don't know what's going to happen because there's too many unknowns. Okay? So Tim goes on and he asks, In the physical therapist world, we tend to diagnose clients with particular syndromes or conditions. To do so, we often use tests which have questionable accuracy. That's an understatement. Or clusters of tests to reduce the likelihood of false positives. Using your model, do you solely rely on a battery of table tests to establish whether someone is in a concentric or eccentric orientation, and not focus on identifying specific signs or symptoms which would be correlated with specific musculoskeletal presentations as commonly taught in PD school? And then he says, do you try to differentiate pathology? So Tim, I'm 30 years removed from physical therapy school. I would hazard to guess there's very little that I do that is left over from that, other than working with humans. So technically speaking, I do not try to identify pathologies, but my model does it for me. So for instance, as I test and I intervene and I remeasure these behaviors that emerge, because of the iterative nature of the movement system, I have a series of checks and balances that allow me to identify these little outlier measurements. And so if I see interference that might be representative of a constraint change or an exapted behavior, again, we will try to intervene to make that change. But a lot of times when we're shooting for this, sorry, that's my little alarm that went off. So a lot of times as we're shooting for this, we might have some form of interference that we can identify as a constraint change, or as you would indicate, a pathology. So again, if I have a true pathology, that inconsistency shows up. So for instance, if I have, I look at shoulder and hip range of motion measures, and so they should mirror one another because of the iterative nature of the movement system. And so if I have one measurement in the shoulder that is unchangeable and symptoms persist, then I might find that I do have a constraint problem. So I would need to send people out for more tests. So if we go back to your buttock pain example, let's just say that we had our person that fell, they go through the acute phase, we move them through the process, we look at them from a complexity standpoint, and we find that something is unchangeable. And so now we say, oh, I might have a synovial joint that can no longer behave normally. I got to send you out for more tests. And so we send them back to the doctor, or however your referral system would work wherever you work. Okay. Tim goes on. This is another question. So patients seem to seek a diagnosis or want to know what's wrong with them. What narrative do you use to not overwhelm them with the complexity of your model? Well, first and foremost, Tim, my model is actually quite simple once you get to using it. But the thing that you want to recognize is first and foremost is don't speak therapist, speak patient. They don't really need to know my model. In fact, they already come to me with a model in their head. So one of the elements of the subjective is to determine what their concerns are. And as you do so, they're going to provide you with a series of beliefs or what their reality may be. And unfortunately, in many cases, because they can go consult Dr. Google, they're going to distort reality to worst case scenarios based on the information that they think that they understand. So you become the one that has to reorient them to reality and hopefully avoid that concept of catastrophization that many people run into. I don't think that they seek a diagnosis per se. What they seek is understanding, and they want to know that they're going to be safe. So calling something a diagnosis tends to put it into this clear, obvious category for a lot of people from a thought standpoint. And that's comforting because obviously if it's clear and obvious, then there's a way to get rid of it or a way to resolve the problem. The goal then is to explain what the possible outcomes may be and how your findings and interventions may actually influence all of these possible outcomes. So again, I've actually had situations where people will come in and we kind of chuckle about this, but they may have sprained their ankle and they might be 40 years old. They've never done anything physical in their life. They've never had a painful situation. So they don't know that the ankle sprains actually resolve and you can walk normally again. And so in that situation, their reality was, it's like, I've never felt this before. What does it mean? I don't understand it. And we give them that understanding and we can immediately put them at ease saying, oh yeah, this thing usually resolves in about 6 to 8 weeks. And in many cases, you go back to normal life and you'll forget about it. So again, keeping them safe and maintaining a continuous narrative as you go through the process is very comforting for them. So we'll do this with how you execute and provide instructions. So whenever possible, you give them a situation of cues to provide internal awareness or an external reference, so they can have an element of control, and that provides them an element of that sense of safety as you go through the process, and you just keep them aware of what's happening. And so again, Tim, I think that you've got a lot of great questions here. Hopefully I touched on something that is useful for you, so you can kind of see how this process works, and how we would differentiate the different ways that we would look at these situations, because I think that this is one of those things that doesn't get expressed enough. It's a very complex situation. We're working with humans. There's different presentations they're going to come into play. There's different ways of looking at things. But again, this is where falling back on an effective model, useful heuristics, good rules of thumb, because we're working in so many possible unknown situations that I think the decision-making process and process in general, as you're working through these situations, is so important. So Tim, thanks for the question. If you guys have any other questions, go to askbillhartman@gmail.com, askbillhartman@gmail.com, and I will see you guys next week.